We're going to open it up to questions now. So I'm going to start with some questions that you guys submitted beforehand. There were a few questions that were common questions. So we're going to start with those. And if you do have any questions, please submit them during the chat. We are happy to answer questions about whatever you guys want to talk about. So I'm going to start with a question that was asked of the residents, which is, how would you describe the relationship with your fellow co-residents? Linda, you want to take this one?
Yes, I would be happy to. Let me just figure out how my video works on this computer. Hello. Hi, everyone. I'm Linda. I'm a third-year resident in general surgery here. The question, how would you describe your relationship with your co-residents? I would say in my year, we all started out pretty close, but in the last 2 years, because of the way that the program is structured, you don't get to see your co-residents as much in second and third year. And so we don't get a lot of other opportunities to see each other outside of work, which is a bit of a shame. However, there isn't a year that I don't know of where they have a group chat, and we often message each other in this group chat. So we are caught up on each other's lives. If we have any issues or questions, I think no one really hesitates to reach out to their co-residents. And I personally also have a few good friends on both below me and above me in training in our program. So I'm very lucky. And I think we're all very comfortable reaching out to each other across the years. It's not one of those programs that's so large or so disjointed that you don't feel comfortable reaching out to people, especially if they are more senior than you. I don't think that's ever been a problem for us. I really enjoy the dynamic in our program because we are all really supportive of each other. And it's a small program, so you do get to know your co-residents above and below you quite well. So I think that's one of our major strengths. And I feel very lucky to.
Linda's just cut out. I'm sure she meant to say to work with Dr. Van Coonet. We will, thank you, Linda. We will ask another question of the residents. And that question is, I think, what's on a lot of people's minds. So can you have a decent work-life balance as a woman in residency for general surgery? Anyone want to take that?
I can speak to that if you like.
Sure. So
hi everyone.
Introduce yourself.
My name is Elaine. I'm one of the recent grads of the program. I'm currently doing my 6th year as an ICU fellow, so I'll be done this coming year in 2021. I had my baby during residency as well, so I had Charlotte during my 2nd year of training. I think in terms of work-life balance, there are definitely good days and bad days. I think it's something that at least that I struggled with from day one, and I continue to work on a daily basis. I think what was most important for me was having realistic expectations and having a very, very supportive partner at home to manage a lot of that. I think in terms of work-life balance, there's going to be times when family will take priority, and there will be times when work takes a priority. And it's going to be walking that line between kind of juggling a lot of balls, but also knowing what you can scale back on and knowing what, there's certain concessions that you're going to have to make in terms of, I basically didn't watch TV for all of residency and knew nothing of what was going on in pop culture, but I read, sang Twinkle Twinkle Little Star 17,000 times a day and read all the children's books. So I think your emphasis changes, your priorities change, and you figure out what's important for you and what you need in your life and kind of balance that. I don't think there's a magic solution for anyone. Say hi. Sorry, she's just about to go to bed and wanted to say goodnight. So I don't think there's a perfect balance either way. But I think if you know what's important to your life and what you value, then it's not too hard to stay on track.
Great, thanks, Elaine. Next question for the residents. Let's see. Couple people asked some version of the question of what aspects of the program led you the most to choose Western for your surgical training? Let's see. How about Jennifer?
Okay. Oh, hi. So I went to Western for med school, and Western was my first choice for residency. I did electives at a bunch of other places, and it just didn't seem the same. I thought that the residents at Western were probably the most like best kind of surgical residents that I'd seen. So by 5th year, they were all independently operating, which wasn't necessarily true of a lot of other places I went to, which I really appreciated. The lack of fellows, I think, contributes to that a lot. Like when I'm on colorectal surgery, it's like me and the staff, and sometimes like Dr. Ott will not scrub for part of the case so that I can like practice to be a staff myself, which is really nice in 5th year. And then also just how the residents are really close in the size of the program, and how the staff are really close to the residents. I think sometimes like at some of the like meet and greets I went to, some of the staff would be like, oh, like nice to meet you, and they'd be like, oh, I'm a 3rd year here, but that doesn't happen at Western. They're all very much in tune to you, so if you're like falling behind, they're definitely going to catch you and not let you fall further behind, which I really liked. And also they trust you a lot on call because they've worked with you so much. So there's not really a getting to know you phase after like the first couple months. They kind of know you. And I did want to go back and kind of add to Linda's comment about how close you are to your co-residents, because we've just been texting in our year. So we're in 5th year, and essentially we're like family at this point. And I was saying that on Wednesday because we have a study group every Wednesday night at my house, and we like all get takeout and study. And I was saying, I texted Luke like an angry thing, and I didn't apologize, which for me is crazy because I am very scared of ever making someone like unhappy. But with family, it's okay. And I was like, oh, Luke, you're family now. I can just like text you angrily and then not have to care about it because you have to love me anyways. So that's like how close we are. I text them about everything. I call them on call when I have clinical questions just to confirm like what I think, and they always give good advice. So really, really close, like family.
Great, thanks, Jen. Maybe we'll ask one of the PGY1s who are now 3 months into residency. How challenging did you find it to match to general surgery, and any tips for the applicants? Sydney or Maddie, you want to take this one?
Sure, I can answer this. I was very nervous about applying, like matching to general surgery. It was the only program I applied to, and I also couples matched, and my partner only applied to one program. We were very stressed out about it. But we managed to couples match and get our like top choice, which was Western. So that was good for us. I think it's, it was hard. Obviously the CRMS tour is very different this year, but it was, sometimes it feels like there's a lot of programs and you don't know how to narrow them down or how to pick. And sometimes it feels like, well, there's like not that many programs, and what if I don't match, and all those concerns. But I think it's good to try and learn as much as you can about programs, to try and know, meet people and talk to people, and really try to figure out what it's like to be a general surgery resident, to be a general surgeon as much as you can. and try to figure out the subtleties of each program and what's important to you. I think one of the things that's so nice about general surgery is it has such a huge breadth and there's so much you can do with it. So I think that's a nice thing about applying and matching to general surgery is that there's so many options in terms of matching to a program, but then there's also so many options in terms of your future career.
I see G has just joined Sydney, so we've got our other two female PGY1s. So you guys, what does your day-to-day life look like as a resident and as a PGY1?
This is the women in surgery.
We're on call right now, so this is what our day-to-day looks like.
We have Team Sushi. It's good.
Yeah, we have Team Sushi. G's got us dinner. It's a lot of work, you know. It's especially in contrast to like having been in quarantine, where you're used to, relaxing for 6 months, and then all of a sudden, you're really working like 5, 6, sometimes 7 days a week. But I mean, G can, correct me if this isn't what she thinks, but I think it's really great. Like, you get to come in every day, do something you're really passionate about, work with these really great people. You see like really amazing stuff every day. So it's a lot of work. It's a lot of time spent at the hospital, a lot of time spent, reading about surgery, thinking about surgery, trying to get better at surgery. But it's, for the time being, at least, it's this is what I wanted to do. This is like really excellent. So I don't mind the fact that like a lot of my time is here. I don't know if G, you have anything to add?
No, it's like you get to do more of what you love. It's really nice, actually. Yeah.
Great, thanks you guys. I see some surprise guests that I'm just so happy to see. So we've heard from Elaine, who just graduated last year, and we've got two of our other graduates who just finished with us in June and who are doing fellowships. So Ali and Lucy have joined us, and they were part of Western's first ever female chief year. So I can't let this opportunity to go by to hear from you. So you have just finished our program. General thoughts that you'd like to share with all the fantastic med students who are thinking of general surgery and thinking of general surgery at Western? Ali and or Lucy.
I'm waiting for Ali to go.
Nope, you're first.
You unmuted, so I thought you were going to share all your wisdom.
I have no wisdom. What was the question again? I'm sorry.
Do you have any general advice for these med students who are considering general surgery and general surgery at Western, having just finished the program?
Yeah, for sure. I think it's hard for you guys because unfortunately you don't get to visit every program in the country. But you should definitely do, these Zoom sessions as much as possible to try to figure out what is the right program for you. For us, like all the other girls have already mentioned, it's really the size of the program and the training that we get that I felt was the best part of the program. Again, your staff, you're like family with your co-residents. For me and, Elaine, Ali, Martina, we just did our exam. We still Zoom like basically every week. We still talk to each other quite a bit. And we still are, there for each other to talk about our fellowship and any issues that we have. So the relationship that you built with your co-residents is like one of the things that you'll never forget for the rest of your life. So it is really important. And I think Western allows you to develop that relationship because it is a smaller program. The same token with the training, you get so much opportunity because there's not that much competition in terms of your operative time. You're the senior on the team, you do all the operations. So like when you're a senior, of course. So I mean, that's my 2 cents about the Western program.
Thanks and congrats. Yeah. Just got married.
Thank you.
Ali?
Yeah, I agree with everything that Lucy said, and everything that like Jen said before about, being how like close you get to be as a year, because there are other smaller programs, but they're more spread out across like sites, I think, and they don't always get to interact with each other every day. So I mean, that was awesome, especially like in COVID times when we're kind of like all on shifts. So it was just really great. I think that I went through like having like come out of that program. I think for me, especially like in fourth year, coming back from doing research, it was kind of like a light switch like flicked on, and all of a sudden you are very much thrust into a reasonable amount of autonomy that like increases with your skills as you learn to operate as a senior and as the decision maker. And I remember when I started fellowship, I was like, you know, people were talking about how many Whipples they'd done and all this kind of stuff, and how many like everything that they'd done coming into fellowship at the institution that I was at. And I was kind of like, shit, I haven't done that many. But then starting to do like Whipples and stuff like that with the staff in this fellowship, I've realized that like they still really do guide you through the dissection and like use dissectors to show you the plane. Whereas I felt that, and that's true, I think, of a lot of the operations that they do, whereas I felt definitely by fifth year that the staff, those included on this chat and otherwise, they're trusting you to show yourself the plane and do your dissections. And like I still remember like the first colectomy where it was just me and Natalie Carey in the room alone. And I was like trying to walk her through it. I was like, shit, I hope that I can like teach this, because it's like you really do get that level of autonomy, which is different, I think, than a lot of other places where you are like doing the case, but really someone's showing you through the whole case. And that's certainly the truth once you're starting your senior years. But I think by the end, you really are doing it alone and learning to teach other people. And I think that that's awesome. And I have like a newfound, I appreciated them, but I have definitely a newfound appreciation for it now too, being on the other side of the residency program. So.
Great, thank you. We miss you, ladies.
More.
All right, next question. We're gonna ask some of the
Sorry, Dr. Van Kunet.
Yeah, Jen, go ahead.
Hey, can maybe not necessarily me, but can someone, when they asked like what a typical day was, I feel like, I don't know if Sydney, they talked about like how much they loved it, obviously, but I don't know if anyone had questions about like what it like actually is like you come in and round, and then we have like 8 to 3 ORs and then 8 to 6 ORs and call and that stuff. I wasn't sure. Someone said yes. I don't know if anyone wanted to talk about like the actual logistics of how Western works, like teaching and all that stuff.
Yeah, so I think let's ask that of a resident and also of the faculty, because it's a little different. Jen, do you want to field this one, or do you want to?
Yeah, I can talk about like maybe the logistics a little. So I'm trying to think from a junior perspective. Your senior resident picks your time. I'm so sorry. Hold on. I'm at my in-laws. Sorry. So you come in generally, you round like an hour or hour and a half before your first clinical duties in the morning, and your senior resident will pick that time. And it's you and the junior resident and the med student that round. And your senior resident really gets to make all the decisions. And we do generally discuss with the staff what our plan is, but most of the time, like by fifth year, I wasn't really discussing day-to-day stuff. I was just saying like, I'm sending this person home, or like, if I was really concerned, I'd be like, hey, I really don't know what I'm doing with this person. Can we talk about it? But, and I did really appreciate the input of the junior residents. So they do have a lot of autonomy, especially during the day when they get paged to take care of things on the floor. And then most days the OR starts at 8. Sometimes we have rounds beforehand. So teaching rounds happen once a week on Wednesday at 7 in the morning. And then teaching, like full half day teaching, happens on Wednesday morning. And then at Western, we do have 8 to 3 ORs and 8 to 6 ORs. 8 to 6 ORs sound like a lot, but it's a really good day to get 2 full large cases in, like 2 full low anteriors, or like a Whipple and something else in, which you don't always get time to do if you don't have an 8 to 6 OR. And then you round at the end of the day, and throughout the day as a junior, you're expected to answer the pager for all the floor patients. And then in terms of call afterwards, we're in a night float system. So you have 1 week of call from Monday to Thursday, and then the rest of the month, you really shouldn't have very much call except for on the weekends. And you go home at like 7 in the morning, and we're pretty forceful about you going home. Even if you want to stay, you should really be going home. I don't know if anyone else has anything to add. The Wednesday morning is protected teaching time. The staff and the residents do teaching together. It's very useful. I don't know if anyone else wants to talk.
How about one of our middle/early seniors? Dora, what's your day-to-day work life like?
Hi guys, I'm Dora. I'm one of the R3s in the program. Right now, I'm in my community rotation. It's a bit different than Vic. We typically start around 7, see all the patients, and then in the community, most of the time as the general surgery resident, you're expected to go to the ORs, and they typically run from 8 to around 3. And then you see everyone on the floor again, and then you stay around for any board cases or any emergency cases that may be happening.
Okay, great, thanks. Thanks, Dora. Let's ask one of the staff the same question. Let's see. Dr. McIver, what's your day-to-day look like?
Well, one of the things that's so awesome about general surgery is that every day is different. I mean, as a resident, you have a fairly usual schedule, but when you're finished, you forget that like you're not in the operating room every day. You have an OR maybe once a week or twice a week if you're lucky, or you do combined cases. So briefly, I guess my week, usually Monday I'm in clinic, in general surgery clinic. And at the end of Monday, I have a sarcoma tumor board to go to. Tuesday, I might do a combined case with one of the plastics surgeons for a breast case, or I might have some academic responsibilities, or I might be trying to catch up on dictations from the clinic day before, or reviewing imaging of a case that's coming up. I'm going down to radiology to review things on my own for, planning and anatomy and things. Wednesday mornings are our general surgery rounds, so look forward to that every week. And that rotates between M&M rounds or case presentations or grand rounds occasionally. And then there's a neuroendocrine tumor board right after that. I'm a surgical oncologist, by the way, I should have said that. I'm going to 4 MDTs a week. So Wednesdays, sometimes I occasionally operate on Wednesdays, or Wednesdays is more academic time. Thursdays is clinic, and another tumor board actually in the morning that day. Friday during the day is often an OR day, or used to be at the cancer clinic, but I usually see most of my cancer patients on Friday clinic day. So each week is a little bit different, and I really like that variety. As far as, how early in the morning you have to get up when you're all finished, thankfully it's not as early as I recall having to get up as a resident. So I'm not a morning person. I think, seems like morning people have an advantage in general surgery residency, but that was always a challenge for me. And I'm here on the other side to tell you, you don't have to be a morning person. But I do try to fit my life around that. And oftentimes I'm able to kind of, now that when you're finished, you do have that ability to plan your time and have a bit more control.
Super, thanks. Let's ask the next question of Dr. Scott. So Dr. Scott, who was featured in Dr. Booter's presentation as a mentor to many of us, what is the work-life balance like when you're a surgeon?
Well, I think I've always been a struggle, and certainly when I was beginning my career and when I was a resident, I didn't know any female surgeons. So I didn't really, don't really think I was focused on work-life balance so much as I was focused on trying to make it work, I guess. And so you know, it was really a challenge in those days, and certainly things have improved a lot. Work-life balance to me means having a life that works for you. And so it's not the same as somebody who has a job that is, you know, 9 to 4 every day, but it is so much more rewarding, and it's the fabric of my life. It's what I love to do. So I do it all the time, just about. In fact, I remember when I was younger, there was a program they were doing on TV, a local thing that was called Behind the Mask, and they were interviewing surgeons about their life, what they did outside of surgery. And they phoned and asked if I would have a program done about my life. I was thinking about that, and I thought, well, I really don't do very much outside of surgery. I come home and then I'm with my kids, right? I loved being with my kids and doing what my husband was listening about his day and making supper together, and things, just simple activities of daily life were exciting to me. So anyways, I said to my kids, well, what would I say? What would I say that I do? And my kids say, oh, that would be great. Well, you like to do crossword puzzles and you like to take naps. So I would say, really, for most of my life, my work-life balance has been doing what I love. And it hasn't been maybe very broad and inclusive, and at times it's been very exhausting. And for certain periods, there were days when I felt like I had to choose between being a bad surgeon or a bad mother. Which was I going to be today? There were times like that. It hasn't been like a piece of cake to work it all out. And certainly I'm not saying I did it right, but it's been extremely rewarding. And I think, you know, one of the most rewarding things has been, not that I wouldn't say I ever thought of myself consciously as a coach or even consciously as a serious mentor, but I've always been proud to support women who came through, and then seeing everybody here today. When I went to meetings, I was often the only one in the women's washroom. There was just nobody else there that I could really share in the same way all the challenges that there are in working it out. And that's not to say I had like fabulous mentors throughout my career who encouraged me and made room for me to do it my way. And those were all men. So in no way am I saying that it's not possible to have great mentorship with men, but there is something special about the relationship I have with other women surgeons and residents that has been a real joy.
Thank you so much for that. Let's see. We've had some questions about, and I'll try to summarize it, that feeling of needing to be extra good or go that extra mile as a female, especially a female who's going after a career in surgery. A question from a few people with regards to, do you feel that extra pressure to be extra good or having to prove yourself as a female surgeon? I'll ask one of the faculty this, and we can ask a resident as well. Dr. Seaman, you've just joined us. I think I saw you there.
Yeah, hi guys. So I just started as a new faculty at Western, but I did my medical school and undergraduate at Western, so I have a little bit of experience there. So I would say that, as women, we do put a lot of pressure on ourselves to be excellent. I think if you want to do surgery, you are going to be striving for excellence. I don't feel that there was particular pressures on me during my training to be better than my male colleagues. I think in a lot of ways, women make really good surgeons because we are very good at multitasking. We tend to be very good at communicating. And I think gone are the days of surgery where you could be a good surgeon, but not be good with patients and not have good bedside manner. I think now we know that those are just as important skills as surgical skills. And I think that women do a really good job of that. So I didn't feel that there was particular pressures on me to be better. But I think everybody in surgery wants to be excellent, which is what you should be striving for. Oh, sorry, my dog's just barking. And I think that there's different challenges that we face as women in surgery, but that things are much different nowadays than they were when Dr. Scott did her training, probably.
Thank you. Question about having kids. Advice for having kids during residency versus waiting until your staff. Is there a good time, and are there advantages to one or the other? Let's ask Dr. Knowles.
Perfect. Hey guys, sorry, I had my video off because I was actually putting my kids to bed. So I apologize in advance if there's any screaming, but yeah, I had kids in residency and in fellowship. And for me, the advantage was that I was able to take time off and not have to leave a practice. So I could take, okay, Marcus, thanks. The kids are trying to get in the video. So I felt like I could take as much time as I needed. I took 9 months with Marcus, but I didn't have to leave a practice or find someone to cover for me or anything like that. Whereas I think if you're a staff, that is a different challenge. You lose income. You have to get someone to cover your practice, potentially a locum and things like that. But then, as Dr. Buder pointed out earlier, you have a little more flexibility in your schedule when you are staff. So taking the time off on maternity leave was great, but then coming back and having small children and trying to write my Royal College exam and trying to finish residency was challenging. But again, I think having a supportive partner and family in the area was very, very helpful. But and then having my daughter in fellowship was actually quite nice because I had, again, a little more control over my schedule, a little less pressure than a residency. And I didn't have an exam at the end of fellowship that I had to leave the kids for studying. So I think there's pros and cons to each. And Dr. Buder highlighted some of the pros to having kids as a staff. So I think you could do either. So sorry, but
Great, thanks, Sarah. We've had a few questions about what it's like to balance having a partner during residency, whether that partner is in medicine or outside of medicine. So I'll ask one of the residents. Lindsay, any thoughts on that?
Hi guys, I'm PGY 3. I'm currently actually away doing a year of community, and I'm in North Bay. So training as a surgical resident with a partner. So I got married before I started residency. My husband spent all of med school with me. I went to NOSM, so we moved a lot. So he was able to come with me on all of those times I had to travel. But in residency, it is hard. I am so lucky to have the partner that I have, because he's very understanding that this is my goal and this is my priority right now. And it's hard to balance it because there are days that, you know, he maybe had a bad day at work and I'm stuck at the hospital on call and not able to really support him. But he understands that this is where I need to be to get to where I want. One of the things that I found really helpful in balancing, he's texting me. One of the things I found really helpful in residency and balancing that relationship is that, one, prioritize your vacation. It is important to take that time and to make sure that your partner takes that time at the same time. And for me, it's important to leave the city. And if I stay in London, I did this, and in my first year regretted it because I would do work the whole time and I really didn't get a chance to relax. So if you have a partner, take the time, take your vacation and spend it with them in somewhere outside of the city to have that time away from the training program, because it is so easy to get completely encompassed in that training program and kind of put off your relationship. But it's very important also to be very upfront with your partner, to know, to tell them how important this is to you, and be very upfront about the time requirements that are needed.
Thanks, Lindsay. We had a few questions about the call structure at London. How much call do you do, and what is call like for a junior? What is call like for a senior? Maybe I'll ask one of the senior residents since they've done both. Robin, do you want to comment on that? What call is like in London?
Yeah. So I guess I'm PGY 5. And call as a senior, you have a lot of autonomy. Basically, how we have it right now is we're the first call to the emergency department, so we get to kind of field all of the consults and kind of decide on prioritizing things. And then we kind of distribute the juniors and the medical students that we have to kind of sort through the night. We will often make a lot of clinical decisions overnight without contacting the staff, and a lot of the times we contact them basically if we know that we have somebody that needs an OR overnight. The rest of the patients get managed pretty well by us. And then we're basically, like Jen was saying earlier, a lot of the times doing most of the operating ourselves, with the staff kind of being our support and talking through the operations with us and kind of problem solving as we go. And then a lot of the like organizational aspects of call are done by the senior residents. As a junior, I think it's a little bit different now than when I did call as a junior, because I wasn't doing the night float system. So I think maybe it might be better to have somebody else talk about that a little bit more. But I think that they still have a lot of autonomy as well. Oftentimes, especially if I have a surgical junior, I'll allow them to kind of just work up a patient and manage them if I know that it's not something that needs an operation overnight, and they'll kind of talk to me about it in the morning.
Maybe we'll go to a junior resident. Evelyn, what was your experience doing call as a PGY1 last year, and what level of support do you have when you're doing call as a junior resident?
All right. Hi guys, I'm Evelyn. I'm one of the R2s here. So yeah, as Robin mentioned, we now do a night float. So it's Monday through Thursday. You're there every night, 5 p.m. to 7 a.m. And it changed a little bit during COVID, but earlier on, we were the ones taking first call from Emerge. And also managing all the floor patients as well. So it could get pretty busy, especially on the weekends too. You really learn how to manage your time and sort of triage things pretty early on. And yeah, so as Robin mentioned, kind of towards the latter half of the year, I did feel that I was getting a lot more independence and more comfort in sort of working people up, figuring out what was going on. And that's not to say that I didn't have any support, like all of the time, like throughout the entire year. I knew that that's always have my senior resident there to back me up if I needed to, even if I knew what was going on and I just needed to check in and say like, this is what I want to do. And they'd say, yep. Or they'd say like, why don't you do this as well? Just a quick thing like that. Or if I was, felt that I needed to, I was stuck and needed to go through something in more depth, really have like a solid review of a patient, senior residents are always there. So I never felt unsupported, but I felt there's a good balance of autonomy and backup as well.
Thanks, Evelyn.
Can I add also that I was going to say, in terms of autonomy, I do know that, none of us have done residency at another school, but Dr. Elnahas, for example, who came from a different school, at least when he started doing call, he would call in and be like, oh, it's really weird that no consults have happened. Are you guys doing okay? And we'd be like, oh yeah, we've seen this many patients and admitted them, just no one needed surgery, so we didn't call. And I know that he, at least having come from different schools, there's a lot more, I think less autonomy at some other schools and a lot more checking in, but here there's very little expectation that you need to check in unless you have questions. You're pretty much expected, well, not expected, but you're allowed to kind of do everything yourself until the point at which you need a staff to come in. Just me.
Great, thanks, ladies. We'll ask one of our PGY5s, Tanya. You've done electives across the country in preparing for fellowship. Maybe I'll have you comment on, it was a common question for both the residents and the staff about what the relationship is like between faculty and residents, level of collegiality at Western. You know, is it still an old boys club? What's the relationship like between faculty and residents at Western?
I mean, I think that's actually one of the strengths of our program, in all honesty, is I think my relationship with the faculty is like pretty stellar across the board. Everybody treats you as a colleague. Obviously, the faculty have final say when it comes to like clinical decision making, but truthfully, I feel like I have fun in the OR. I have fun working with the people, and that's true for every single rotation I've had. I've never felt like I've been dismissed. It's been actually pretty awesome. I feel like one of the benefits of Western is that the faculty really get to know you as a resident, and really from PGY 1 until PGY 5, and they kind of watch you grow, know your strengths and weaknesses, can gear your surgical education to your own needs, and really help you achieve your own goals. I feel like finding mentors has never been an issue for me. I've had some fantastic mentors along the way, both female and male. They've always been very supportive of my career goals, have always been there for me. There's lots of faculty have like an open door policy where you can just walk in and chat. I definitely crashed Dr. Van Kunitz's office multiple times just to talk to her. So I think
Steal all
honestly,
the
pardon?
And steal all the chocolate.
And steal all the chocolate, yes. Well, there's like multiple flavors. You got to try them all. I honestly think that's a great strength of the program here. And it's people who I'd feel, comfortable texting afterwards too for advice and stuff once I'm practicing as my own, have my own practice. So, which is not something you get at a lot of different programs, partly because there's just too many sites, there's too many residents. So I think that's very much a unique aspect of our program. And so you kind of do have the benefit of like prolonged mentorship over 5 years. And so that's one of our greatest strengths, in my honest opinion.
Great, thanks, Tanya. I'll open this up to the group at large. What is the ethnic diversity like in our program? And do minorities feel like they stick out in the hospital or in London? Anyone want to field that?
I've never felt like I stuck out. We also do have a lot of Asian residents, I think, in our training program. But I found when I came into London that from Toronto, and which is where I did my undergrad, I found that there's still very good diversity within the hospital system. There's people from all walks of life, from all ethnicities. Oftentimes, it's almost helpful if you have other backgrounds because there's patients who don't speak English. And if you know a second language, being able to communicate with patients from that aspect is super, super useful. So I've never felt like I stuck out or that there were any racist comments or anything like that were mean and had bad intention behind them. I've had a couple of comments where like from patients, which were a bit questionable, but it was not made in malice. Good night. But it was not made in malice or anything like that. And but anyways, so I don't think that's really an issue in London that I found.
Thanks, Elaine. Maybe we'll ask Dr. Vogt, are you still on the line? I know you're putting your kids to bed as well. That's a no. Dr. Buder, what do you look for in a good applicant to general surgery?
Well, I mean, certainly seeing electives, which, in this sort of time is, I guess everybody will do electives in their home institution, but certainly seeing that they've done surgical electives, general surgery electives, and showing an interest. Now, of course, there are people who sort of come late to the game like I did, so their CV may look a little bit different. Yeah, but basically, you know, what's been their past experience? Why do they want to do surgery? What is it about surgery that excites them? What's their long-term plan? So I think those are the main things that we're looking at.
Great, thanks. Dr. Vogt, how do you deal with being in what is still a male-dominated specialty and subspecialty of trauma? Do you feel like there are subspecialties within general surgery that are not very friendly to females? Her audio is still not working, despite it supposedly working. Shall I field that one then? Or are there any other residents or staff that I haven't asked a question to that want to answer that question? Anything within general surgery or other subspecialties that are more friendly to women or less friendly to women?
Dr. Van Koenen, I think you should answer that one. I think you're uniquely qualified, probably.
Well, my subspecialty is colorectal surgery. And, you know, of the 5 colorectal surgeons in London, I am the only female colorectal surgeon. That's not to say that colorectal surgery per se is male dominated, because there are quite a lot of female colorectal surgeons. You know, I don't feel like there are any areas within general surgery, especially here at Western, that discourages women. But I do think there are certain subspecialties that, you know, for whatever reason, do attract more women. And I would say, I think part of that is fears about work-life balance, especially if you imagine being, you know, let's say a transplant surgeon with a unpredictable schedule. That might not seem appealing when you're you know, when you have young children or are thinking of having young children. And there are other subspecialties that might seem friendlier in that there are not as many long days or not as many inpatients that might free up your schedule. But I do think that the nice thing about being a general surgeon is that there are so many options on how you shape your career. So you can work in a large center where you don't have to do very much call, or you can work in a small community where you do a bit of everything and you do have a fair bit of call. You can be in a subspecialty where there are a lot of women or not a lot of women. And you can be in subspecialties where you do very big, complex surgeries, or very small, or a mix, which is what my practice is, which I really like, a real mix of things in my day-to-day work. Are there challenges to being a female surgeon? Of course there are. You know, I think sometimes, as surprising as it is in 2020, sometimes patients are still, and not sometimes, often, very surprised that I'm a female when they meet me for the first time. And, you know, sometimes you do catch a whiff of them questioning your judgment as a woman. But I do think that is changing, thank goodness. And I think as clear from our night tonight, I think, you know, I wouldn't choose anything different than colorectal surgery. I love what I do. And I think there's challenges to every job. I'm just going to go back to the chat here. The question about the proportion of residents that pursue fellowships or work in the community. And are there opportunities during residency to really explore the options? Let's ask Dr. Ott, our program director.
Okay, so we have a lot of flexibility in our program. I think you've heard that already. where we try and focus primarily on what the resident wants to accomplish. So I think Lindsay and Rachel, who are on the call this evening, are examples of that. So we expose people to community surgery very early on in the residency training program, and then in the time that people have available in the later years, we then can add more to that. Generally, we've been training residents in 4 years. Even though it's a 5-year program, our clinical volumes allow us to do that. And so there's about 10 to 11 blocks of wiggle room that we can play with. With the Competency by Design, that's shifting more to the end of training. But I saw a question asking about things like C-sections or hand surgery. And if you know that you're going to be working in a community for that, the transition to practice can be done to obtain those skills. So I think if you ask most of the residents, one of the things that we pride ourselves on is focusing on what they want to do. And so usually we don't give you too much grief in the first year, but in the second year, as you meet with me every 6 months, one of the big questions is, what do you want to do with your life and how are we going to get you there? And so that's how we build your residency training program for the most part around that. So there is a fair amount of availability in the community, and community just doesn't mean things that are outside London, although that's available to you, but as far away as Vancouver and far north, because for example, Lindsay wants to work in Northern Ontario when she's done. So what better place to go and do her community rotation than Northern Ontario? And as Rachel mentioned, she really wanted to get a leg up in BC, and also we thought that would be a nice dovetail into allowing her to spend a little bit more time with her partner and her children. So that was the way we approached that. So there's a lot of flexibility, and we support. If I look statistically, I would say that probably somewhere in the neighborhood of 60 to 70% would pursue fellowship, but that changes from year to year. Our current crop of third-year residents are almost all interested in community surgery, whereas our last year of people who graduated all wanted to do fellowship training. So there's a flavor from year to year and different individuals. We don't really try and promote one or the other. But overall, I would say somewhere around 60 to 70%. I think that answers the question.
Great, thanks. And in terms of the differences between working in the academic center here in London or working in the community centers around London, a couple people asked about how a community rotation differs than an academic rotation. Maybe let's go back to Lindsay, since you were just mentioned. Lindsay, how are things different when you're working in London or when you're working in a community rotation?
So things are they're similar in the sense that there's a lot of really big surgeries still happening in the community. There's some people who kind of have the misnomer that all the big stuff happens in the academic center, and that's not necessarily true. For example, the other day we did a laparoscopic toupee fundoplication for a gastric volvulus, and we did it in North Bay here, or we do colectomies when I was in St. Thomas. So what kind of differs is that you're often the only resident on service. So you generally have maybe a few fewer patients. So that's not always true. But you're taking on the responsibility of what typically is a junior resident, and then also what is typically the senior's responsibilities. The staff in the community are more used to doing things, are being the MRP and not having residents around. So I do find that depending on where you go, certain staff have certain various particular preferences. And so I am more often running things past them just because I know that they have preferences that I'm not used to. Whereas when I was a junior in London, I kind of got to decide what I wanted to do. The other thing that's a little bit different is the way that the culture works. I find that at times in an academic center, it can be a little bit us versus them, which is very frustrating at times. And there's the the turf battle over certain procedures or turfing patients to other services, and that really doesn't happen in the community as much in the community. The Emerge staff, you work with them to kind of provide the best care to, very sick patients in Emerge. And if they have a patient overnight that they think maybe has a gallbladder, they will tell you in the morning instead of calling you at 3 o'clock in the morning for a patient that they think has a gallbladder and or has acute cholecystitis without imaging. So they kind of are out to protect one another and protect everyone's time, which I think is really nice in the community. They're great rotations.
Hi guys, can you hear me? I was just kicked off for a minute. Sorry about that.
Yep, you're good.
Okay, great. Sorry, I had to switch devices. I don't know what happened. So I missed the end of Lindsay's answer, but thanks, Lindsay, for answering that. Let's open it up to the group again with a bit of a toughie, especially in front of a crowd, but the applicants want us to get real. We've talked about a lot of positives about our program. What are some of the weaknesses? Anyone want to tackle that?
I can start from a senior perspective. I think one of the difficulties, as with a lot of the training programs currently, I think within general surgery, is kind of the balance of service to education. As the Royal College have kind of cut down on funded spots for surgical training programs, kind of in balancing with job opportunities and such, it does leave sometimes shortages, I think, in programs where residents are having to work more, take more call, and there's sometimes an emphasis on service based on the established culture and everything that's kind of has been in the system before that, which doesn't change as quickly as, when numbers acutely drop for a variety of reasons. In my 4th and 5th year, I know just by virtue of how the numbers worked, we went quite quickly from having 14 seniors down to 8 seniors in a span of 2 years. And that was definitely a huge adjustment for everyone involved, staff and residents alike. The way that our program was set up, I remember as a junior in my R1 to 3 years, the teams were a certain size, everyone was adjusted to that. And then when we lost, numbers, or our numbers decreased because of a variety of different reasons, essentially what that meant was that the teams had to be reshuffled. The teams got bigger, it got busier for the seniors who were managing the teams. So there was a lot of readjustments that had to be made in terms of, realistic expectations for what our day-to-day would start looking like, and how much call was going to be needed, right? But I think as along the way, the program has been supportive. Dr. Ah has definitely been a champion in trying to advocate for us, as well as residents, to find a good balance. And the emphasis always is still on education, but knowing that, there are going to be times when some of the emphasis has to shift a little bit towards service too. So I think that's maybe one of the weaknesses that I found in my last 2 years of training was that acute change, that adjustment process, which I think is also because when we're a junior, you see what the seniors are going through and you have this expectation of what your senior years are going to look like in terms of how much call you're going to do, how much time you'll have to study and everything. And then it's uncomfortable sometimes when you get there and you realize this wasn't what I expected, because now for a variety of different reasons, we're having to do more call until later, or the teams are bigger, so the clinical volume is higher, it's busier, and there's always upsides and downsides to the situation, right? Higher clinical volumes, more patients, more surgeries means you get to do more and see more, but it's longer hours in the OR, it's longer days, rounding before and after, less time with family at night. so kind of that adjustment period was quite challenging. And I think our program is still adjusting to some of those number changes. I would say for me, I found that to be one of the biggest weaknesses, but it's an ongoing process. And I think Dr. Ott and the staff involved have been very willing to engage and try and come up with viable solutions that work for the staff, work for the residents, work for education, while still ensuring that patient care is not compromised.
I kind of just want to add to that. While I agree with Elaine, I think that's something that we struggle with here, but I also come to this with the perspective, like I was on the CAGS residence committee. I've gone to electives in multiple programs across the country. And the truth of the matter is this is an issue that programs are struggling with across the country. And that's just to do with the reduced number of residency positions across the country. And so this is something that people are trying to work out everywhere, and nobody has a perfect solution. But I do agree with Elaine that I think if there's one issue that's come up during our residency, it's just kind of, I think, it's more so around issues around the call schedule. But as Elaine has mentioned, I think our program leadership has been extremely supportive, and they've really kind of gone above and beyond to try to fix some of these things for us and try to support us through this process. In particular, Dr. Ott, I would say. So.
Tanya, while we're on you and you're muted, for the residents or for the medical students who are applying, what do you think the applicants need to look for specifically in a program when they're looking at different programs across the country?
So I think, well, from my perspective, I think you're committing to a program for 5 years. I think you need to find a program where I think you get along with the people, where, because you're going to be, for no matter where you go, doesn't matter which general surgery program you choose, you're going to be working hard, you're going to be spending a ton of time in hospital, and you're going to be doing a lot of call. And so you need to really, I think, enjoy the people you're working with, enjoy the faculty you're working with. And then so that's one thing, because you're going to be spending a lot of time with these people. I'm biased, but I think the people at Western are the best. I think the people in my year are the best. I think the residents here are the best. So then the second thing you want to make sure that you come out competent at the end of your 5 years of training. And so this is you want to make sure that you get the educational experiences that you need to know what you want to do. And I think things like autonomy in the OR and outside of the OR are incredibly important, because that's the hard stuff. When you're left there by yourself to try to make that decision in the operating room as well as outside of the operating room, that's where you kind of experience a lot of growth. And you also recognize how much the staff's actually doing for you when they're in the room. And so you do need those opportunities. I think Western, and again, multiple programs will offer this, but I think we get exposure to pretty much all the subspecialties at Western, and you do get to basically bring all that expertise into your own practice. And I think we're doing some pretty impressive stuff at Western. I just finished my HBB rotation, for instance, and I was involved in things like laparoscopic Whipples. You're not going to be doing that elsewhere, right? And that's true no matter where. If you're in the colorectal service, both at UH and at Vic, you're the one who's doing those cases. There's no fellow in the room doing those cases instead of you. When you're in the bariatric service, you're the one who's doing the intracorporeal anastomosis. You're the one who's doing all these things, and you get to incorporate that into your own practice going forward. And so I think you want to pick a program. I think those are the things you really want to focus on, is figure out what you want to be after you finish, and make sure that you're competent enough to have those skills in your own practice. And then also you want to enjoy your time, because it's 5 years. 5 years is actually quite some time, and you want to make sure you actually enjoy your life while you're in the program. So I think those are all very important factors.
Great, thanks. So we've been talking for an hour and a half, and I think we could talk forever about residency and being a surgeon and being a woman as a surgeon, but I think we'll start bringing things to a close. So wondering if we'll start with the residents, any final comments for the medical students who are on the phone or on the line, or anything that you wanted to say earlier that was asked of someone else that you'd like to add in closing? We've said it all. For the faculty, any advice or tips or comments that you'd like to make before we sign off?
Can I just say one thing for the medical students? It's Rachel. I think this year, of course, it's very different with COVID. You're not allowed to do out of province electives. So I think that's probably giving a lot of people a lot of stress. And I just really want all the applicants to know that, you know, everybody's in the same boat and not to stress too much about things. Looking back in my own application experience, I just thought, if there was one thing that I could tell myself, it's just take the time to enjoy medical school more, learn and be a good doctor first. That's what you're doing in medical school. Don't worry too much about, you know, applying and dedicating all of your time and attention to this. So I think just relax for now, take a deep breath, know that everybody's in this together, and don't be too stressed out.
I will echo and add to that. Thank you, Rachel. I know you all are feeling like you're being screwed this year, and in some ways you are, and that CARMS is going to be very different this year. But, you know, please know that your applications will be taken seriously, that you are all in the same boat across the country, that all the programs, you know, are still really invested in this match. We want you to succeed. Your homeschool does, and we do here. And, you know, when it comes time for CARMS, the nice thing for you guys is all of us old surgeons are now going to be a year into using Zoom and doing things electronically and through video. It'll be old hat, and the virtual interviews will go well, and hopefully they'll all go very smoothly, and hopefully CARMS will go well for you. You have this extra pressure this year because of how things are shaping up with the pandemic, and your medical school has been turned upside down, but everyone in the country is rooting for you, and you will all be treated equally, and you will all be giving opportunities, and hopefully you will end up in a program that you're very happy at, and that's the right fit for you. That may or may not be Western. You know, every program is a little bit of a different vibe. We certainly think that we have a fantastic program and one of the best programs in the country, and we hope that you'll, you know, consider taking a look at us, read our website, email the residents, email the staff. We're all happy to help you see if Western is a good fit for you, because this isn't just about us picking you, it's also about you picking us. And so we're here to help you.